A very good evening, everyone. Myself, G. Arunagiri from Government Medical College, Tiruvallur, and I'll be hosting this session today. I will heartily welcome our AATRAL STAR faculty, Dr. Apeksha Anand ma'am, and today's presenter, Dr. Lavanya ma'am. I would request Dr. Jamuna Rani ma'am to grace this occasion. Over to you, ma'am.
Yeah. So good evening, one and all. So respected State President Dr. Abul Hasan sir, JDN Chairman Dr. Hariharan sir, and faculty Dr. Apeksha Anand and the presenter Lavanya. So it's a great pleasure today, and I think we are making Abul sir's vision, which is the AATRAL platform, a reality today, and we had a series of lectures in medicine and pediatrics for the last week. And we had session on 25th where Dr. Anirudh Srinivasan, he covered CVS, and 26th, Dr. Prasanna Karthik covered respiratory system. Wednesday, Dr. Lakshmanan covered CNS, and Thursday, Dr. Jagadishan covered abdomen. All these sessions had minimum of 300 participants who stayed throughout the session. And 22nd, we had pediatrics by Dr. Apeksha, where we exceeded our Zoom limit of 500, and we have to live stream the video as well. And 23rd, again, pediatrics by Apeksha, where we had 300 students. Nephrotic syndrome was covered, and 29, again, cyanotic heart disease. So that was covered, and today we are waiting for acyanotic heart disease. And there was an overwhelming response from students across Tamil Nadu. And there was a request for surgery and OBG as well, which will be covered as a rapid session with high-yielding topics as a single-day session. Tuesday, OBG, and Wednesday will be surgery. So we would like to really congratulate each and every participant who has contributed in this. And the student coordinators, Dr. Joel Stuvertt from Tagore Medical College, our MSN convener, Dr. Somnath from Katpagavinayaga, MSN co-convener, Praveen from Madras Medical College, the academic committee, AATRAL convener, and Arunagiri from Tiruvallur Medical College, who has been hosting all these sessions. I also congratulate the presenters, Sona, Shrija, Aishwarya, Karan, Magna, Swati, and Lavanya, all from Tagore Medical College, batch of 2019, for presenting the cases. So I congratulate each and every one of you, and really thank you for all your amazing responses, and we'll be hosting more sessions in the future. Thank you, one and all, and I request our State President, Dr. Abul Hasan sir, to say a few words and also wish our students best of luck for their upcoming practical examination. Thank you. Over to Abul Hasan sir.
Thank you, Dr. Jamuna. Good evening, my dear friends.
Good evening, sir.
Good evening, sir.
Good evening, sir.
Cut ಆಯ್ತು.
Sir, Karthik Prabhu sir has joined. Meanwhile, Karthik Prabhu sir can share a few words with the students.
Yeah. Good evening, everybody. And respected President and leaders of JDN, you're doing a wonderful job. I'm inside the flight. Sorry, I need to. I've been asked to cut my phone. So best wishes for the exam. Great job. And keep in touch. Best wishes to all. Thank you.
Thank you, sir. Thank you so much, sir.
Thank you, sir. Thank you, sir. Over to Abul Hasan, sir.
Thank you, Dr. Jamuna, Dr. Hari, and Dr. Karthik. It's wonderful that IMA MSN flag is flying very high in Tamil Nadu, and particularly this AATRAL program. I'm very happy that it is going on without any break and going on in full swing. Thanks to Dr. Joel, CT, and Somnath, of course, Jamuna and Hari. It has been, kind of first of its kind in the entire country. I want to actually develop this AATRAL idea into a permanent kind of skill lab that is being planned in our headquarters building, Tambaram. Very soon it will be a reality. And I think after some time we will have a bigger meeting and call national president and national office bearers also to see how much work we are doing in the MSN platform in Tamil Nadu. And I wish all the delegates very good, best, and wish them all good luck for the forthcoming practical exams and also examinations. Wish you all the best. And congratulate all those people, my dear boys and girls, involved in this wonderful venture of AATRAL. Thank you very much, Dr. Jamuna. Over to you. And wish you all the delegates a good day today.
Thank you.
Thank you, sir.
so
Thank
much.
you, sir. Thank you for your presence, sir. Sir, I request Dr. Hariharan, sir, to share a few words, then we'll start the session.
Thank you, Dr. Jamuna. I think it is great to see young people working hard to help each other do. I think the JDN is helping the MSN hand holding, and we are doing great things together. So let us do more things and take IMA flags higher. So thank you so much for the opportunity. Thank you for working hard for this. Thank you so much.
Thank you, sir. Thank you, sir. We would like to thank our State President Abul Hasan, sir, and State Secretary Dr. Karthik Prabhu, sir, and JDN Chairman Dr. Hariharan, sir, for sharing their valuable time and wishing our students good luck. So thank you, sirs. And over to Dr. Apeksha for another wonderful, fantastic session.
Thank you.
Over to you, dear. Thank you.
Thank you so much for giving me this opportunity. It was really nice to be part of JDN MSN and also these young minds. So they make me study more, motivate me more, and do better every day. So they're literally asking me such tough questions which I didn't expect. So it was very nice for me to be a faculty. So we'll do more. And I'm sure they'll all do exams very well. Very sincerely, they've been following up everything and they ask me doubts. They personally message me also some doubts. So it's very nice. Thank you for the opportunity.
Thank you, dear. Thank you, dear. Over to Arunagiri to start the academic session. Thank you.
Yes, ma'am.
Lavanya, can you share your slides? We'll start.
Yes, ma'am, sure. Ma'am, is the slide visible, ma'am?
Not yet.
One second. Now, ma'am?
Yes, you can share it. Yeah.
Hello, ma'am, is it visible now, ma'am?
Yes, yes, you can start.
Oh, okay. Am I audible, ma'am?
Yes,
Okay, ma'am.
very clear. Yes, start.
A very good evening to one and all present here. Good evening, ma'am. Ma'am, today's presentation is Acyanotic heart disease. Demographic details. Baby named Aradhana, 8 months old girl child from Ratnamangalam, accompanied by her mother. The reliability is good. Chief complaints: the baby has cold for 5 days, cough for 5 days, fever for 3 days, fast breathing for 2 days. History of presenting illness. The mother gave history that the child has a recurrent respiratory illness 3 months of age or since 3 months of age, and currently she has brought to the hospital with similar complaints of cold for 5 days, which was insidious in onset, progressive, associated with sputum, which was mucoid in nature, and cough was incidence in onset, progressive for 5 days, which was very type of cough, aggravated on lying down. Fever was present for 3 days, which was incidence and gradually progressive and relieved on oral medications. Baby had fast breathing for the past 2 days, and breathing was purely abdominal, not associated with bluish discoloration of skin and mucous membrane, and lower chest retractions was also present. History of poor feeding was present, and the mother started top up feed from the 3rd month. History of suck, rest, suck cycle was present while breastfeeding during 3rd month. History of forehead sweating was present during feeding. History of poor weight gain was present according to the mother. No history of decreased urine output. No history of fever. No history of microscopic hematuria. No history of bluish discoloration of skin and mucous membrane. No history of oliguria. No history of fever with rash. No history of abnormal movements. Past history. History of recurrent respiratory tract
Lavanya,
illness
we'll
was
stop
present.
here. Lavanya, we'll stop here. Can you go to the previous slide?
Yes, ma'am. Yes.
Okay, so go back to the chief complaint. Okay, so you have told cold, cough, fever, and fast breathing. So what all systems can you think of if you're thinking these 4 symptoms?
Ma'am, first of all, I would go with the respiratory system, ma'am.
Very good. Okay. Okay, next. So you should
From
always
the
have in
other
mind maybe
complaints,
respiratory or cardiac. Okay, next. Okay, so in your history of presenting illness, so I have few corrections for you. See, cold will not have sputum, so make that one correction when you're explaining. And in pediatrics, the sputum is very difficult, so the child will not be expectorating. So cold will probably in the form of running nose or in the form of nasal stuffiness, right? So probably you wanted to tell it for cough, so you have missed it, so it's fine, not a problem.
Okay.
But in exam, make sure cold will be probably in the form of stuffy nose. Okay, so what do you think is the problem with these things? Cold, cough, fever, and fast breathing. So what do you think the child has?
The child has some kind of rest.
Lavanya, your voice is breaking. Your voice is breaking, Lavanya.
Most commonly, it can be a lower respiratory tract. Ma'am? Hello?
Your voice is breaking.
How about now, ma'am?
Yeah, now it's okay. Can you repeat it again?
Ma'am, first with a cold, cough, fever, I suspect some kind of lower respiratory tract illness, ma'am.
Okay, very good. So what in these do you think is more of a lower respiratory and why not upper respiratory?
Ma'am, child has fast breathing, ma'am. First of all, then the child is also having cough, ma'am.
Okay, very fine. So fast breathing is more towards something which is lower respiratory. Okay. Why have you specifically mentioned bluish discoloration of the skin?
Severity of the disease, ma'am. It indicates the severity of the disease. If there is any
any cyanosis,
and also
right?
the patient any severity. Yes, ma'am.
Okay. So always remember, whenever you're putting anything in your history.
Can I change to the next slide?
Yes, please. Okay. Can you tell us why you have asked this history? Poor feeding, sucrose suck cycle?
Ma'am, I have asked this for involvement of the CVS cardiovascular system also, ma'am. If there is any signs of congestive cardiac failure.
Okay. So the mother doesn't give any history of cardiac disease. So why are you thinking this and asking this history?
Since the child has a recurrent respiratory
very
hello,
good,
ma'am.
correct.
Can I hear? I can't hear you, ma'am.
You're correct. Go ahead.
Okay, ma'am. Hello.
Yes,
hello,
go ahead.
ma'am.
Yes, go ahead. Go ahead. We can hear you.
Yes, ma'am. Since the child has a recurrent respiratory illness, and since this is third episode, even though the child is treated with antibiotics and hospitalization, the child is again and again having a respiratory tract illnesses, ma'am. So that pushed me towards thinking about some serious pathology, underlying serious pathology, giving rise to respiratory tract infections.
Very
I'm suspecting, ma'am.
So very clear. Okay, so this is how you're going to substantiate whatever you're asking. So this is how you will be even asked leading questions. Why are you unnecessarily asking all these things? Because the mother never said there is any cardiac. That means you already know the case. So this is how you have to tell. So the child is having recurrent respiratory tract infection. So I would like to think of something other than respiratory. Excellent. Very good. Okay. Then why have you asked for decreased urine output and oliguria? Right. So decreased urine output and oliguria are the same. So you have missed some things which are to be asked. So what are the features? What are the complications you can get if it is a heart disease?
Complications are infective endocarditis.
Okay, very nice. So for that you have asked. What you have asked?
I have asked fever, microscopic hematuria, then oliguria is there.
Okay, very good. Then
splenomegaly is there.
Okay.
Then,
next, what about edema? What about? Why do you ask for edema?
No. Since edema, congestive cardiac failure, if the patient, if baby is presenting congestive cardiac failure, edema can also be present, ma'am.
Excellent. So you're supposed to ask that one thing, because so what type of lesion will cause congestive cardiac failure? Because yesterday we discussed the other part. So I'll ask you today. So what lesion are you thinking of? What type of cardiac problem are you thinking in mind? So it's a left to right shunt disease with pulmonary congestion.
Yes.
So that will cause repeated respiratory tract infection, and also what will it cause? All these symptoms of failure, right? So yesterday we discussed that in TOF, it rarely causes congestive cardiac failure. Okay, so I have a question here. I like to take it. Can palpitations be present? See, children cannot. Palpitation is perception of the fast heart rate, right? So a small 8-month-old child cannot tell palpitations. So at this point, we cannot comment. See, if it's a bigger child, if it's a rheumatic fever, rheumatic heart disease, so the child is bigger. So yes, he can perceive a palpitation. Okay, next, past history.
Past history of recurrent respiratory tract illness was present. 3 episodes in the past 8 months. History of 1 hospital admission was present in the past for the respiratory tract illness. First episode during the 3rd month started as a respiratory tract illness, was treated on the OP basis with oral medication and nebulization. Second episode during the 6th month started as a respiratory tract illness, patient was hospitalized and treated with IV medications and nebulization for the 7 days. Third episode is a current episode, which also started as a respiratory tract illness. No history of any other similar illnesses in the past. Antenatal history.
Okay. So any other illnesses in the past? What do you want to say? Why are you telling that any other illnesses in the past? What do you mean any other illness?
Any other illnesses like a normal fever or any other fever with rash or any congenital symptoms.
Congenital? Okay, it's okay. See, so when you are asking a history of
infections, ma'am, like sequelae of the.
Okay, so you don't have to mention about it. So in the past history, we are only bothered about the recurrent respiratory tract infections, and we want to know the severity of the infection. Okay, so hospitalization you have mentioned.
Yes, ma'am.
And did the mother at any point mention that the child was started on any medicine and is continuing to give? No? Lavanya, are you there? Can you hear me?
Ma'am, hello. Hello.
Yes, your network has some problem.
Okay,
anybody? Yes, anybody else wants to tell me what is the importance of giving any other medicine?
You know only, ma'am.
Yes, we are having some trouble with Lavanya's network. Okay, we'll discuss. The rest of us can discuss until she joins us back. So it's important for us to ask treatment history. Okay, see, infective endocarditis, yes, you should think of when it's a bigger child. So our child is just 8 months. So the chances of infective endocarditis is not very high. Yes, penicillin prophylaxis, this will be for something bigger. So any other medicine they give if the child is having ventricular septal defect? Anything you people know to prevent cardiac failure? Yes, diuretics. See, digoxin is not used, so we use diuretics. Okay, furosemide, very nice. So the mother sometimes gives history that the child was asked to give some drops every day. Okay, Lavanya, are you back?
Yes, ma'am. Sorry, ma'am.
Okay.
Sorry.
Nah, no problem. Okay, we'll continue. Okay, we'll discuss in the end so that we are not wasting much time. Okay. So you should ask about treatment history of any other medications which has been given. Okay, continuously. So that's what we were discussing, that any diuretics or something will be given to prevent failure. Okay, right. Antenatal, go ahead.
Hello.
Hello, yes, start, my dear. Start antenatal.
Yes, ma'am. First trimester, pregnancy was confirmed by urine registered for pregnancy at Ratnamangalam PHC. Dating scan was done at 11 weeks. Iron and folic acid supplements were taken. History of vomiting and nausea was present. No history of fever with rash in the first trimester. No history of spotting PV or bleeding PV. No history of irradiation in the first trimester. In the second trimester, anomaly scan was taken. No anomalies found. Tdap 2 doses were given at 16 and 20 weeks. Calcium supplements were given. Iron and folic acid continued. Quickening felt at the 5th month. No history of heart disease complicating pregnancy in the mother. No history of hypertension complicating pregnancy in mother. No history of diabetes mellitus complicating pregnancy in mother. No history of infection in the second trimester. No history of antepartum hemorrhage or spotting or bleeding PV. No history of any chronic illnesses during pregnancy. No history of UTI during pregnancy. No history of fever with abdominal pain during pregnancy. No history of any drug intake during pregnancy.
Okay. So we'll go to the first trimester again. So first trimester, the drug intake is probably goes to the first trimester. Okay. So any history of drugs, any history of. So can you tell me some maternal diseases which in first trimester which you're worried about, which will cause some cardiac problems?
Ma'am, congenital rubella syndrome, ma'am.
So what cardiac lesions do you expect in congenital rubella?
Ma'am, VSD first of all, then PDA, ma'am.
Very good. So PDA is more common. So you can also expect VSD, ASD, or pulmonary artery problems, stenosis. Right. Okay. Next. What else? What else are you worried?
Then VSD, ma'am. Then
yeah. What other condition in the mother are you worried about? Which will cause some cardiac problem. Anybody else? Mums. Okay. Mums will cause. Yeah. Mums. Okay, it might not cause VSD, ASD. Okay, but still, yeah, it can affect the heart. Yes, GDM, gestational diabetes mellitus, will cause either cardiomyopathy, transposition of great arteries, and also VSD. Okay, so at least 2 conditions, risk factors you should know. Okay, can you tell me some drugs which can cause cardiac problems? Any one drug at least? Yes, okay. Your friends are answering. Lithium, valproate, very good. Thalidomide. Okay, fine. They all answered for you. Okay. Second trimester. It's okay. Next. Can you switch your slide, Lavanya?
Is it not visible now, ma'am? It's not visible now?
Yeah. Now we can see. Right. So second trimester, so the anomaly scan was done. So do you think we can find out a VSD in anomaly scan? Okay, for the others until she gets back. So anomaly scan is taken at what weeks? 22 weeks. Yes. So normally if it's a large VSD, ASD, we can find out.
Hello?
And the yes, you're audible. And if the radiologist is suspicious, then we advise a fetal echo. So fetal echo is done exclusively to look at these cardiac lesions. Okay. So fetal echo is also done at 22 weeks. Okay, what is happening to her video, audio? There's some problem.
I'm back, ma'am. I have a poor net connection, ma'am.
Okay, it's okay. Okay. So when you are describing the second trimester, you might not have to tell all these things in detail. So you can just tell that there is no history suggestive of gestational diabetes mellitus. So if they ask, what are the symptoms of gestational diabetes mellitus, you will answer. Okay, so what are the symptoms you ask for?
Hello, ma'am. Am I audible, ma'am?
Yes. Polyuria, yes, everybody is answering. Polyuria.
Polyuria, polydipsia, polyphagia.
Okay. Right. Okay. So what I would prefer you writing is there is no history suggestive of gestational diabetes mellitus, gestational hypertension. There is no history suggestive of any urinary tract infection, and there's no history of bleeding per vaginum, leaking per vaginum. Okay, no foul smelling discharge. Okay, so you don't have to tell that no history of fever with abdominal pain during pregnancy. No, so those things are exclusively specific, and you can try in probably obstetrics. Okay, pediatrics and this it might not be required. Next, third trimester.
No history of spotting PV or bleeding PV. No history of fever. Membranes ruptured spontaneously. Spontaneous onset of labor was present. Natal history, full-term normal vaginal delivery. Baby cried immediately after birth. Birth weight 2 kg 600 grams. Breastfeeding was started within 30 minutes of birth. Child was breastfed for 3 months. Stop up feed from the 3rd month due to difficulty in feeding. Breastfeeding continued till date. No history of NICU admissions.
Okay.
Developmental history, radial grasp achieved, sits without support and crawls, waves by. Nutritional history, the
Okay,
required
so one
calorie
thing I
for the
want to, one second, can you
age.
stop? So at this point, I want you to elaborate a little of developmental history when it
Yes.
comes to acyanotic heart disease, because of the underlying condition. So the child tends to have a motor delay. Okay, so you have to specifically tell gross motor, fine motor, language, and social, along with the developmental quotient. It is expected here. Okay.
Okay, ma'am.
Next, nutrition.
Nutrition history, the required calories for the age is 504 kilocalories, but there is but the current calorie intake is 463 kilocalories. A deficit of 41 kilocalories is present. Ma'am, do I need to explain about the table also, ma'am?
No, no need. Okay, so he has some calorie deficit also. Okay. Next.
Immunization history, fully immunization scar was present in the left upper arm. Last vaccination given was Pentavac and OPV2 given at 3 months, that is 10th week of birth. Optional vaccination is not given. Family history,
One
child was
second.
born out of
One
non-conceived.
second. 1 second. So normally the last vaccine is 14 weeks. Okay. 6, 10, and 14. 10th is the second vaccine. Okay, so if you have written it's fully
Yes,
immunized till date, then it will be the last vaccine will be, if it's Penta and OPV given at 3 months, 10 weeks, that means they have missed the 14th week vaccine. Right? So what are the vaccines given in 14th week now? As per national immunization schedule. The schedule is changed little this year. Are you all aware of it? I think I told it last week about the national schedule. Okay. Pentavalent, OPV, IPV,
Okay, ma'am, I'll
Rota,
update it.
and pneumococcal. Okay, you are going to get all these three in 14 weeks. For 10 weeks, what you have written is correct. You are getting only OPV and Penta. Right. Okay. Family history.
Family history is a child was born out of non-consanguineous marriage. No history of similar illnesses in the family, and that is a pedigree chart.
Okay.
Provisional diagnosis: Master Aradhana, 8 months old girl baby was brought to the hospital by her mother with complaints of recurrent respiratory tract illness, with signs of failure to thrive and no signs of cardiac or respiratory failure. Most probably a lower respiratory tract illness, but it does not rule out a cardiac disease.
Okay. So can you just summarize the history for us? Just the history. Can you summarize your history?
Yes, ma'am. Yes, ma'am. Master Aradhana, 8 months old girl baby child, was brought with the complaints of cough and cold for 5 days, fever for cough, cold, and fever, and fast breathing. She also has signs of poor feeding. Sucrose cycle was present. Then poor feeding,
Then
sucrose cycle was present. History of forehead sweating was also present. History of recurrent respiratory tract illness was present, which was 3 episodes in the past 8 months. History of poor feeding was present, and complementary babies are completely breastfed till 3 months, after which she was started on a complementary feeding and continued till date. And then Can I check the previous slides? I think I'm missing out something.
Okay, no problem. So you'll please get ready with the summary always, okay?
I've added in the last slide, ma'am, as a complete summary of the entire case.
Okay, fine, no problem. Okay, so normally at the end of history, you will be asked to summarize, and then at the end of examination, you will have to summarize both history and examination. Okay.
Okay. Can I move to the general examination now?
Yes, we'll go to the general examination.
On examination, patient was dull, drowsy, tired, moderately active, conscious, tachypneic, pallor present. No interest, cyanosis, clubbing, generalized lymphadenopathy, and pedal edema was present. Head to foot examination, head appears to be normal, front nails closed, no frontal bossing, eyes and orbit normal, ear orbit, nose appears to be congested, throat mild congestion present, chest wall appears to be normal, external genitalia normal, limbs normal. Anthropometry, weight is currently 6.3 kgs, which is less than 2 standard deviation, and it is currently in the 3rd percentile according to WHO standard growth charts. Length is 64 centimeters. That is also minus 2 standard deviation. Mid-arm circumference is 9 centimeters, minus 2 standard deviation. Head circumference is 40.7 centimeters. That is also minus 2 standard deviation. Chest circumference 38.7 centimeters, minus 2 standard deviations. Everything is under the 3rd percentile, ma'am, and according to WHO growth charts, ma'am.
Okay, so for us here, from the general examination, our child has pallor, and our child looks dull, lethargic, right? And I want to ask if the frontal is actually closed. What age does the frontal closes? Anybody in the audience? What age does the frontal close? Anybody is answering fast? Okay, 18 months. Okay, so yes, it can vary, but 8 months I'm not very sure if it's closed. So normally it takes 12 to 18 months for the frontal to close, as far as I remember reading. Okay, so yes, that's one thing. So limbs, why are you asking limbs? What can be present when there is a cardiac problem? What are you looking at in the limbs? So there can be syndactyly.
Maybe the baby is associated with Down syndrome, syndactyly, or anything.
There can be Downs, there can be syndactyly, polydactyly. So whenever you see a child with these things, you have to also screen the cardiac. Okay, next. And also his anthropometry is below. So the child is failing to thrive. Okay. Then vitals.
Yes. Vitals, pulse rate 150 beats per minute, normal sinus rhythm, large volume bounding pulse in the radial artery is present, BP 85 by bar 60 mmHg, respiratory rate 60 times per minute, temperature 100.3 febrile, SpO2 92% in room air, increase to 96% with oxygen.
Okay. So do you think the child pulse rate is normal? So you can write it as heart rate, okay, in children. So normally the heart rate, okay, and respiratory rate will be 60 cycles per minute, okay, it will be cycles.
Okay.
Right, okay. So pulse, you think it's normal for the age?
Yes, ma'am.
Yes? Yes? Everybody agrees with her, it's yes? Okay, two things you have to remember when you're thinking about a cardiac condition and a respiratory condition along with fever. So congestive cardiac failure, the first sign will be tachycardia. So the heart rate increases. So probably a 8-month-old child, the heart rate of around 120 to 140 is normal. So 150 is a little on the higher end, but the child is having a temperature. So every 1 degree increase in temperature increases the heart rate by how much? 10. Okay, so once you correct the conditions and then you check the basal heart rate, you will find out, because we want to rule out if the child is having tachycardia because of the cardiac failure, or tachycardia because of hypoxia and a respiratory problem, or tachycardia because of fever alone. Okay, so you should remember all these things. Clear? Next, proceed.
Yes, ma'am. Systemic examination. On inspection, chest wall appears to be symmetrical with no chest wall deformities.
Which system are you examining?
No
which system do you want to examine?
Bulge, no engorgement. First, I would go with the serious examination, ma'am. Then I will continue with the respiratory system.
Why not respiratory first? We know the child is having a respiratory problem, no? So why
Hello,
not
ma'am.
respiratory problem?
Am I audible?
Yes. So I want to know why not respiratory first and why cardiac first?
Ma'am, because I think the underlying problem is basically from the CVS, ma'am. So I would like to rule out the CVS first, then go with the respiratory tract.
Okay. See, mostly when you are presenting, what we would expect is for the current problem, what do you want to tell? So it would have been better if you tell the respiratory first and then cardiac, okay? Because we don't have any features of failure as of now.
Okay, ma'am.
Right? Okay, it's okay. You can go ahead. It's just, I'm just trying to tell you. No, you start. No, you finish the cardiac and then we'll go. Yes.
Okay. Okay, ma'am. No problem. Chest wall appears to be symmetrical with no chest wall deformities, no precordial bulge, no engorged veins over the chest. Trachea appears to be in midline. No other visible pulsations over the chest. No scars, sinuses, dilated veins over the chest wall. On palpation, trachea seen in the midline. Apical impulse felt at the left fourth and fifth intercostal space in the midclavicular line and hyperdynamic. Palpable thrill present at the left upper sternal border. No percussion, heart percussion is not done. On auscultation, S1, S2 heard. Pansystolic murmur, grade 4, best heard in the left sternal border, with high pitched and with thrill. Respiratory system, upper airway examination. The nose is congested, no flaring, oral cavity normal, throat mild congestion, tonsils normal. On inspection, use of accessory muscles of neck not present, but subcostal retractions present. No nasal flaring present. Apical impulse not visible. On palpation, chest expansion decreased on the right side. Vocal tremor is not done. On percussion, impaired dullness over the right mammary, right infraaxillary, and right infrascapular areas present. On auscultation, bilateral expiratory wheeze heard over
Lavanya, you're not audible. I mean, your voice is getting stuck. Lavanya, we are
infrascapular
not audible. Your voice is getting stuck.
area. Crepitations heard over the infrascapular area. Other systems, abdomen normal, no.
Okay, so she said we have lost her connection. It's okay, until she comes back we can discuss. So what I want to highlight at this point is, so when the child has come with the symptoms of respiratory system like cold, cough, fever, so start with respiratory system examination, because you don't know what is the underlying cardiac condition, so it may or may not be there. So based on our history and findings, we are like trying to assume that okay, the child is having some cardiac problem. So that doesn't mean that you should start with the cardiac system. So the child has come with cold, cough, fever, and fast breathing. So we are going ahead and starting with the respiratory system examination. And respiratory system exam starts with upper airway, and then you have to start with inspection, palpation, percussion, and auscultation. Vocal fremitus, we don't do it in pediatrics. Vocal resonance, all these are not there. So on palpation, you can just see if the chest movements are symmetrical, and that also will be a little tough in pediatrics. Okay. So one thing which will be very easy is your auscultation. So auscultatory findings are very important coming to respiratory. Okay. Then cardiac, then yes. So based on her history, so our cardiac problems, so she told, I think I don't, her positive findings were the child had a grade 4 murmur and it had thrill, right? And it was in the fourth intercostal space, right? Best heard. So all these things point out towards a ventricular septal defect. Okay, so anything else you want to ask? Any doubts until she's back so that we can discuss? So somebody has asked, why does forehead sweating and cycle happen? Okay, so these things happen because it's a pressure is overloaded, right? So from there is a it's a volume overload condition. So there is, because of the shunt, there is increased in the hemodynamic burden. So the in the physiology of VSD, what we know is, so the blood is shunted from left ventricle to the right ventricle, right? So from the right ventricle, it goes through the pulmonary veins, and then it goes and comes back to the left atrium. So left atrium also tends to get dilated. So there is pressure overload in the right ventricle, volume overload in the left ventricle. Yes, so that is why there is recurrent respiratory tract, because there is pulmonary. Okay, so recurrent respiratory tract criteria, mostly it is more than or equal to 3 respiratory tract infections requiring admission and hospitalization, 1 per year. More than or equal to 3 is what we tell as a standard. You can say that that's enough at your level.
Hello, ma'am.
Okay, normal apical. Yes, are you back? Okay, we were discussing
Yes,
in your
ma'am.
absence. So the normal apical impulse in children, yes. So normally it is present from birth to 3 years. It's at fourth intercostal space in the mid clavicular line, and then after that it starts moving. Then it comes to the fifth intercostal space, just lateral, and then after like adolescence, it comes to the fifth intercostal space medial to the mid clavicular line. That is what is seen in adults. So in pediatrics, it is fourth. So, okay, we'll go ahead. Lavanya, are you there?
Yes, ma'am. Yes, ma'am.
Okay. Okay, we can go we finished the examination part. So can you tell me the positive findings of respiratory examination and cardiovascular examination?
Yes, ma'am. For starting with the cardiovascular examination, ma'am.
Just tell me the positive points.
On
Okay,
ma'am, okay, ma'am. Ma'am, there was a palpable thrill present at the left upper sternal border, ma'am.
Very good.
Then
Apical
on
impulse.
auscultation, there's a
Apical
pansystolic
impulse.
murmur of grade 4.
Apical impulse is hyperdynamic.
Yes, ma'am. Hyperdynamic, ma'am.
Yes.
And on auscultation, pansystolic murmur or grade 4 is present, which is high pitched with and also present with thrill, ma'am.
Okay. So these are the 3 positive points which are pointing us towards a ventricular septal defect, which is a left to right shunt lesion. Okay. Next, what are the positive points in respiratory system examination?
Respiratory system examination, the upper airway, nose is congested.
No. Tell me the positive points
there
only.
is mild
Tell me the
congestion.
positive points. I just want the positive points. Okay, I'll
There is
summarize for her.
subcostal
Okay.
retractions present.
Okay, I'll summarize for you because we are running short of time. So the positive points in respiratory exam will be subcostal retractions that involves either a parenchyma or lower airway. Then chest expansion, she is specifically told on the right side. Probably we are dealing with the right-sided pathology. There is a dull note. Probably the pathology is in the right infraaxillary and mammary region. So right lower lobe is involved. So there is some wheeze and crepitations in that area. So we have a pathology which is respiratory on the right side. Okay, next. Okay, one more thing I wanted to add here is abdominal system exam becomes very important, especially liver. Okay, so if there is a pathology in the right side of the lung, the liver tends to be pushed down. So that should not be confused for a hepatomegaly, because hepatomegaly is also possible here because we are having an underlying cardiac condition. So there is chances that the child will have CCF. So that will cause a hepatomegaly. So you are expected to measure and write the liver span. Okay. So don't just mention organomegaly. You have to even write the liver span, because liver will definitely be pushed on with a respiratory illness and with a pathology in the right side. Okay. Next.
Yes, ma'am. Summary: a 8-month-old girl baby with complaints of upper respiratory tract illness, cough, fever, and tachypnea with signs of failure to thrive was admitted. History shows suggestive of recurrent respiratory tract illness present with 2 previous episodes of lower respiratory tract illness for which the baby was admitted once and treated with oral and parenteral medication. On examination, baby is drowsy, tired, conscious, moderately active, and tachypneic. Baby is having 100.3 degree temperature with a large volume and a bounding pulse. On auscultation, a pansystolic murmur of grade 4 was heard at the left left sternal border with a high-pitched thrill and expiratory wheeze bilaterally heard over the chest at an infrascapular area. A diagnosis of lower respiratory tract illness, mostly due to underlying cardiac pathology, most commonly acyanotic heart disease, probably a ventricular septal defect is suspected. Diagnosis: a case of acyanotic congenital heart disease, probably ventricle septal defect with a lower respiratory tract illness and known signs of cardiac failure or respiratory failure.
So I would like to revise the diagnosis. I would like to say it's a case of lower respiratory tract infection first with an underlying acyanotic congenital heart disease. So now the child's main problem is the respiratory, right? So that should come as your first part, and then it will go with underlying acyanotic congenital heart disease with failure to thrive and with no signs of cardiac failure. So why do you say there is no respiratory failure? So you said room saturation is 92% and with oxygen it's 96%. So the room air saturation is less, right?
Yes, ma'am. The room air saturation is less only, ma'am. It is around
It was 92%.
in
Yeah.
92% in room air, ma'am.
So what is a normal room air saturation do you expect?
Room air saturation is about 99%, ma'am.
No. In pediatrics, more than 94 is considered normal. Okay. And then it is improved to 96 with oxygen. So that is why it's not in failure. It's probably an impending failure because there is of low room air saturation. Okay. So when you're telling the summary, you don't have to mention the temperature. The child is febrile. You can tell that. Okay.
Okay, ma'am.
Okay. Can you tell me why do you think it's VSD and not ASD or PDA or other pectoral shunt lesions?
Ma'am, first of all, on auscultation, there is a pansystolic number, ma'am. So
Okay.
then there is a large volume pulse, ma'am. Large volume bounding pulse in the radial artery, ma'am.
So anything in your history which is suggestive that it is VSD? Age of presentation, right? The child has presented by 2 to 3 months. So at what weeks it generally presents ventricular septal defect?
Usually by 4 weeks, 3 to 4 weeks, ma'am.
It's probably 4 to 6 weeks.
3 to 4
it
weeks.
takes 6 weeks.
Okay.
So what are the types of ventricular septal defect? Because you said it's a VSD. So what are the types of VSD? Can you tell me?
There are 2 types of VSD, ma'am. Membranous VSD and muscular VSD, ma'am.
Okay. So what is the most common type of VSD?
Most common is membranous type is most common VSD.
Okay. So what do you want to do in this child? Now our child has a respiratory problem. You know there might be cardiac problem. So the mother does not know it's a cardiac problem. So what all investigations do you want to do?
Ma'am, I want to do first of all, I wanted to do a complete hemogram, ma'am. Then echocardiogram 2D image. Then ECG and a chest X-ray, ma'am.
Okay. So do you want to rule out any infections underlying? So you might have to do a respiratory panel if required, right?
Panel.
You can tell that. Okay. So child is having fever, cold, cough, fast breathing. So I would first try to rule out any underlying respiratory illness. Then since I am suspecting some cardiac disease, I would like to do an echocardiogram. Okay. Then, so how do you want to manage this child?
First, I want to admit the child. Then start the child on IV antibiotics. Then nebulization with bronchodilators. Meanwhile, I'll continue the breastfeeding and also after the discharge, I'll advise the patient to maintain a good oral hygiene. On discharge, I'll also correct the malnutrition with good feeding practices.
Okay.
And I advise the mother with yearly follow-up.
Okay. So
And also, I will advise for.
Is this lesion size of VSD here? Is it mild? Is it moderate? Or it's severe? Based on your symptoms. So do you think it requires surgery? Do you want to tell the mother about that?
No, ma'am. I'll advise the mother to wait until 4 years for spontaneous closure. Until 4 years, we'll also have a yearly follow-up.
Okay.
So after 4 years, if the child is having a large VSD, if there is also cardiac failure, hello?
Okay, okay. So one thing
If
I
there
would
is
like
also
to
cardiac
correct.
failure.
Okay, so it's good what you know. Spontaneous closure actually happens in 50% of the cases, but our child probably has a large lesion based on your history, because child is having recurrent respiratory tract infection. It's been third. This is the second admission, which is severe and requiring antibiotics and oxygen. So probably the size of the lesion is a large VSD. And also you said thrill. So if there is a thrill, and if there is a grade 4 murmur, probably it is a and failure to thrive. So all these things point out towards a large VSD. And if it's affecting the child's growth and causing infection, yes, you don't have to wait till 4 years. Okay, so when you are counseling, so you might even be asked to counsel a mother like this. So be careful of what type of lesion it is before you are counseling. So what you told is absolutely right. If it was a small VSD, okay, small VSD normally will not cause recurrent respiratory tract infection. So small VSD is probably less than 5 mm is what we called as small. So 5 less than 5 mm, 5 to 10 mm, and more than 10 mm is large. Okay, so more than 1 centimeters is large. So that you have to be careful. Okay, right, good. Anyway, it was a good presentation. It's fine. These are some things which are beyond. If you are asked these questions, think that you have already cleared your exam. Okay, these are mostly postgraduate level questions which might not be asked to you. Very good. So we have finished our presentation. So what symptoms will be there in small? Yes, see, any VSD will present with succus cycle, forehead sweating, but it is, see, the age of presentation might not be 6 weeks. So the child might develop at a later stage. So, and they will also have cold, cough repeatedly. So it might not have severe symptoms like what she has mentioned. Okay, so it's pretty much the same. The lesion is the same. It's a left to right shunt which is happening. Age of presentation of ASD, normally ASD is incidentally detected, so we don't know what exactly. Sometimes you detect even in adolescents. JVP raised can be seen probably more than 5 years, because neck is very small in children and you can only see the JVP when you can see the neck properly. So more than 5 years you can see. Okay, then anything else? I answered, I think. I have answered most of it. What causes forehead sweating? I already told. No, it's because of the shunt, left to right shunt. So there is a pressure overload, there's a volume overload, so the child is struggling to breathe because of the shunt. Okay, why not other acyanotic heart disease? What do you want to ask, Deepak? I'm not getting your question. Okay, anything else? Lavanya, you want to ask anything else? You have any doubts? It was a very good presentation.
Nothing, ma'am. Clear, ma'am. Thank you, ma'am.
Very good effort. Okay, so she's almost covered everything possible, and it's very detailed, and it was very good for us to discuss. Okay, so it's almost
Ma'am,
10,
I
and
have a
today,
doubt, ma'am.
yes, tell me.
Ma'am, do we need to add any other vaccinations other than the national immunization schedule,
See,
especially for this child, ma'am?
yes, especially for this child, we have to recommend flu vaccine. Hello, I'm sorry. Yes, flu vaccine is something we recommend because it will prevent in recurrent respiratory tract infection, and you should also make sure that they have got the pneumococcal vaccine. These are the two vaccines which are very important. Flu vaccine is given at 6 months and 7 months, okay? 1 month apart.
Okay, ma'am. Thank you. Thank you.
QPQS ratio, yes, somebody wants to know, somebody wants to be a cardiologist here. Yes, QPQS ratio comes into significance when you are deciding on the surgery. Okay, so that when the criteria for surgery will be if the patient is older than 2 years that time, and the QPQS ratio is greater than 2 is to 1, that is when it's an indication for surgical closure. But for this child, patient at any age with a large defect and with clinical symptoms of failure to thrive can be operated. Okay, okay. treatment part for this child. Okay, so treatment part first, we have to treat the underlying respiratory tract infection. We have to find out what is the size of VSD. If the child is having features of failure, we will start on anti-failure medications, and then we have to put across a decision of surgical closure once the child is hemodynamically stable, and also take care of the nutrition and the immunization part, because he has missed the 14 weeks vaccine. There's no optional vaccines put. Okay, so this much at least you're supposed to tell. Okay, so I think we can end the session. So I wish all my students the very best in the exams. So it was a very short notice and I tried to cover as much as possible. I didn't want to take much time of yours. So I'm sure all of you will do well, and we'll see you all as colleagues and doctors in your internship. So we will probably continue the series. We'll ask the next batches what they want and how we want to proceed. This was extremely fast and quick because I was mostly concentrating on the exam going students and I didn't want them to miss anything before their exam. So the rest the coordinators can help, and then we can have detailed session one by one. And any doubts, you can please text me or whatever, mail me, Insta or email ID you have, and I'll try to clear it. Thank you, the whole team. Joel, are you there? Arun,
Yes,
are you there?
Yes,
Thank
yes,
you so
ma'am.
much.
Yes, ma'am.
It's been a very nice 2 weeks for me, and you're all very amazing, and it was very happy for me to teach you all.
Thank you so
thank you
much,
so
ma'am.
much, ma'am. Thank you so much.
I really enjoyed it. So next, Arun has to present the case. Not only host, okay? You're in final year no?
In pre-final year, ma'am. I'm
Pre-final year.
currently
It's
in
okay.
pre-final year.
It's okay. Pre-final years have 1 month of pediatric posting. I know that.
Definitely, ma'am. Sure.
Okay, right. So you can plan the other sessions and let me know what type you want, and the seniors also can join. Those all who are interested in pediatrics, you can know more about pediatrics from me.
Sure, ma'am.
Sure,
Let
ma'am.
me know.
You will all do well in your exams. Remember, stay calm. You don't know, you don't know. Okay? Don't take risk and be confident in what you know. That's all. If you forget anything also, just close your eyes at that moment and say, tell, at this point I'm unable to recall. Good luck, guys.
Thank you. Thank you so much, ma'am, for this amazing session and for your wonderful insights and your wishes for everyone
Yes,
here.
we'll see you back after some days once they're all done with their exams.
Yeah, sure, ma'am.
Bye.
Thank you so
Thank
much,
you.
ma'am. Thank you. Yeah, we end our pediatric session. All the sessions were uploaded in IMA MSN Tamilnadu YouTube channel. You can visit in any time. Hope the sessions will aid in your university exam practical preparation. We are planning for surgery and OBG sessions in upcoming days. We will update the session schedule in the AATRAL groups. Stay tuned. Thanks for joining. Happy learning. Thank you so much for everyone.
Bye.
Thank you, ma'am. Bye, ma'am.